Good morning. Dr. Marc here, sitting with Dr. Rob.
Morning.
Wanted to talk briefly about our hygiene experience, our hygiene patients that come in for cleanings. And we get a lot of feedback from our patients. Some people feel sometimes a cleaning could be too gentle, or others feel it could be too rough. We have 7 hygienists in our practice, and they all practice differently, just like the dentists in our office. Some have a harder touch than others. Some patients like that soft touch, and they don't want to feel anything, where other patients feel like, hey, if I'm not feeling anything, I'm not getting a proper cleaning. I think the outcome of both cleanings are the same. The purpose is to remove tartar or calculus. Obviously, if a patient has more tartar or more calculus, the hygienist might be reaching further under the gum, a little bit more pressure on the tissue, which could cause a little bit more discomfort. The hygienists in our office do use different types of numbing gels, sometimes even anesthesia, if needed for that situation. So what we like to ask our patients is try to get some feedback from our patients, right?
Yeah.
Some people don't want to feel anything, and some people feel like, hey, I didn't feel anything. I didn't get a great cleaning.
It's incredibly consistent across the board. And I don't want to use the word frustration for us, but it is in a sense because you and I and the doctors here are doing hygiene exams. So when you're examining a patient after a cleaning, you're looking for all the dental diseases possible to try to prevent things, cavities, and gummies, but you're also looking for the calculus and tartar. You're looking at every space.
Correct.
So from your observation, we can agree that there are different experiences of the hygienist in our practice. How many of them are leaving things behind?
None. Yeah, the tartar's gone on whether it would have a soft touch or a harder touch.
Yeah. So I had a husband and wife, and the husband saw one hygienist, the wife saw another hygienist, and they said to me, I want my wife to see who I saw.
Correct.
The person who my wife saw wasn't as thorough, is how she felt. Now, I remember it was a few weeks after, the conversation we had was a few weeks after their appointment. And I remember seeing the patient in the hygiene room. She was spotless. Her mouth was spotless. There was no tartar, no staining left behind, no calculus. So she received
A proper hygiene.
biologically, she received a great hygiene appointment, but her perception wasn't such. And so there's a misconception in our practice, and you and I talk about this a lot, the misconception with patients with how it feels to what it actually is.
Yeah. And I relate that to flossing. Someone could floss and go under the gum a little bit more, and you'll feel a little bit more pressure against your tissue than you would if you're just gently going between the teeth. We know that both types of hygienists are getting the same result.
And which is the right result.
Which is the right result.
Yeah.
So sometimes we just need a little bit more feedback from the patient, what they want to experience at that visit.
I think that's what Marc and I speak about around this conversation is that, and all of these OMD talks that we're doing, all these our social media and the videos that we put out to patients, is what we're trying to do is overall empower our patients to be the best advocate for themselves, to have a voice through their actions on how you take care of yourself. And also when you're here with us or the hygienist or any doctor that you see, any healthcare professional, is to think about how you're receiving that care and to communicate it. It's great to say you're doing a great job, but it's also okay with our team, especially, to say, hey, you're a little too rough, can you let, or I don't feel like you're going deep enough as you need to go. Can we talk about that?
Right. And sometimes it could be various numbing agents that are used, topical anesthesia that preventing the patient from feeling anything, right? And they could be going as vigorous as
they need to be, right?
Correct.
In I guess part of the problem around this, so there's one is a perception. Some patients have a style they like for hygiene appointments, but there's also a need. There's a need that has to be done. And there's a set of patients who have a great deal of buildup. They haven't had a cleaning at the interval they needed to, or they're just terribly susceptible. And they need to have a thorough cleaning to get all of the calculus off. And that is going to be an uncomfortable thing. There's no way around it. The inflammation around the calculus and tartar.
It's fair to say it's possible that they may need more than one cleaning visit to remove all of that tartar if it's been more than 6 months since a cleaning.
Yeah, so we work hard with our hygienists about the experience of a hygiene appointment.
It's fair to say, I think the most important factor is the communication, both from the hygienist and from the patient, for the patient to relate to the hygienist what they want to experience during that visit.
I guess not to be self-interested here, but we can say that we know that the hygienists on our team are doing an exceptional job for every patient, for every cleaning. The experience may be preferential for a patient of how it can be, just to communicate, like Marc said, you're doing double click on that. Communicate with us and your hygienist at the time of the hygiene appointment. 5 or 10 minutes into the hygiene appointment, you know how it's going. Right.
Because when you hear that afterwards, it's tough. Yeah, and says, I wish I would have had a little deeper cleaning, or I wish I would have felt less. And that could have been resolved if the better communication, the patient and the dentist and the hygienist.
I guess our practice, we feel very focused about this, that our patients are our boss. You are our boss while you're in the office. We're taking care of you as an extension of your needs and wants. And so make sure you communicate with the hygienist or us about what those are. And sometimes you might have a need or a want that is not consistent with the reality to take care of you.
Rob, you told me an interesting story I'd like you to repeat. We compare like Kim and Eric massage.
Kim and Eric.
Compare the cleaning to a massage, right? A tissue massage. Mm-hmm. And the different variations of that.
I have a physical therapy team. Doing dentistry is not the best thing for your body, maybe, and sometimes in trying, Marc and I try to work out, take really good care of ourselves, and so I see physical therapists regularly. And it's Kim or Erica, two different people. So Kim is tough, fast, and efficient with getting, if I have a body issue, if I have a muscular issue, because sometimes your muscles may be pulling on your skeleton and you have a soreness in the joint or something.
So you'll feel her a little bit.
So Kim, you're going to feel a little bit. And then, when Erica does the same type of destination and get things realigned, she'll put slow, constant pressure on the same muscle. And it feels like she's not doing anything.
And what's your outcome?
The outcome is that you stand up after and you feel great. You feel from both experiences. Extremely opposite styles, but we get to the same destination. We're talking preparation for this. About this. I'm like, it's the same thing with Kim and Erica. We go through 2 different types of experiences, and yet you feel great after. You feel less restricted. My knee feels better, or my shoulder, whatever it is. So.
Good.
Just getting and communicating. I laugh with Kim and Erica about this, actually. I laugh with their style differences.
Let's talk about what we do a lot of our practices. We're restorative practices, so we do a lot of crowns, which are made out of different types of ceramic material. But sometimes you have that tooth that's not severely broken down. It's a small cavity. It's in between, or maybe it needs a larger filling, and we struggle between the question, do we do a composite plastic restoration, which is under $1,000, compared to a ceramic restoration, which is more than that. And the variations in both, which is stronger, which is weaker. The composite is cheaper. Maybe it's only going to last a few years, and we go back and forth with our patients with that, and we try to advocate what's the best for their mouth for every situation, depending if the patient's a grinder or not. You may need to cover the tooth more. So let's talk about the difference between the composite and the plastic compared to a ceramic restoration.
Like you said, we are a restorative practice. We're not doing root canals and extraction and surgery. So almost all day, every day, we're doing restorations, whether on teeth or implants. But when it comes down to teeth and cavities, we have a choice a lot of times on the type of material we can use. And patients commonly will say, I do not want a crown. I'd like a filling. Or opinion other way, I want only ceramic and I don't want a filling. So I just want to dive deeper into this.
Marc, and
it would be worthwhile to kind of go through in a couple of minutes the short version of this topic, because it's better if you think about it philosophically beforehand than when you're in the treatment room. It might help people, so we can again advocate for you on the solution you want. So a cavity, it eats away the tooth. There's a hole in the tooth. So Marc and I, or the doctors here, will mechanically go in there and remove the tooth structure that's affected by the cavity. So you have a hole in the tooth. So you have an object, right, like a roundish or oval object, and there's a whole space missing. And so we have to figure out how to support that, to fill it with the material and support it functionally, the mechanical function of the tooth, and biologically the health of the mouth with that material. We no longer have to do only large ceramic. So back in the day, it was either a filling or a crown, for black or white. Now we have an intermediate solution called inlays or onlays, which is made of the same materials that we make crowns of, ceramic, like Marc said, but they can be as conservative as the filling would be. right?
Correct.
Okay. So a filling versus a ceramic restoration. The filling is made of 3 different materials, right? There's a filler matrix, the matrix, filler particles, which are silica. The matrix is a plastic. Bis-GMA is the most commonly used. And then there's a coupling agent to bind the matrix with the filler particles. So it's like baking a cake and putting chocolate chips or sprinkles in different sizes. And so that matrix, the matrix is, it would hold all together, and the filler particles, it has to be 70% or more. So you're going to have this like mixture of a lot of chocolate chips and sprinkles just bound together with the cake mix. And so it's loose, and then we pack it into a tube, and we hit it with a light and cure it. And that's going to make the cake from being a batter to an actual cake, right? That's a pretty good analogy. But I want people to be able to visualize what this is in their mouth versus
compared to
a ceramic restoration, which is a fibered piece of glass, right? It's a ceramic is a glass particle, glass restoration that fills the space that's made outside of your mouth. The main thing that happens when you're baking that cake, when you're making the filling from soft to hard, is you're having shrinkage. You're having shrinkage that is incorporated to, it's called polymerization shrinkage. From the material, when it sets, it kind of bounds together. That inherently causes some stress between the tooth and the filling itself. That's one.
Where the two surfaces come together.
That's one. The second thing we think about is what happens with the material when it's exposed to hot and cold. So hot causes the molecules in the tooth to get more excited, and then they become bigger, thermal expansion. When it becomes colder, the molecules become less active, and the material shrinks. So
where the ceramic material, what you get,
right, ceramic
versus composite, you're going to get less shrinkage,
is identical as to
enamel.
Yeah, we won't get into the measurements, but it is identical to enamel and dentin, where the filling material is 5 to 10 times different,
softer,
different. Well, the expansion and contractions happening at a rate that's 5 to 10 times different to the actual tooth surface. So the aging of this material is expanding, contracting, and the gap where the tooth and the restoration meet as stress. So you have 2 stresses with the filling. The filling, you have 2 main stresses. Number one is that polymerization shrinkage causes internal stress between the enamel, the dentin, and the restoration. That causes it to grade faster, where with the inlay or onlay ceramic material, it's near identical, and the gap is fitting more stably. And then, like we said, the gap is being stressed more with the filling material as it's exposed to temperature changes. So it's expanding, contracting, swelling at the 2 different rates. So it causes more tension. You have this these two things that are happening on a chemical basis, that the filling is breaking down faster than the inlay onlay, causing microgaps for bacteria can get into faster.
So now talk about when you introduce the bite on top of that. When someone's grinding, the wear is a person wearing to ceramic restoration.
Right. And so a filling wears 2.5 times more than the enamel tooth surface. On average. There's some that are more,
which will open that gap up.
The ones that are prettier wear more. So a filling that looks better is a softer filling, typically, because it has smaller particles in it, smaller sprinkles and chocolate chips. And so it can polish more, but that wears more because it's just smaller, softer particles versus the higher filled rate. So we, in our practice, use different composites for posterior and anterior, ones that are more polishable versus ones that are filled more. So those are the 3 main things to think about. Is the polymerization shrinkage on setting of it happens with a filling, doesn't happen with an inlay or onlay. The coefficients of thermal expansion and contraction, that happens with a filling, not with an inlay or onlay. And then the wear rate, like you said, it's much more similar to tooth surface.
Correct.
So you can then say, well, let's take those components and look at the actual literature around the performance. And so for most of the literature around filling survival shows that they become susceptible to getting a decay 3 years out.
Mm-hmm.
We have patients who have fillings that are over 10 years old, but on average, a filling, the chemical bond to the interface between the tooth and the restoration, you have 3 years on it.
And you add to someone who is a grinder or a clencher, that's going to wear even faster.
For patients that are susceptible for periodontal disease, you're going to get more bacteria around the margin of that filling.
Correct.
For people with susceptible cavities, you're going to get more bacteria around that margin. Now, they can last more than 3 years. Of course they do. but the process of the breaking down begins at 3 years. Now, the other side of the coin, if you look at the survival of a ceramic restoration, the 10-year survival of ceramic restorations are in the 90 percentile. Now, you look, depending on the studies, it's funny, I have a client who makes EMAX. Their studies are like 98% survival in 15 years. That's not for ceramic. That's not right. But most of the studies that are done independently are in the 90 percentile for 10 years.
If you group them all together, if you separate inlays and maybe onlays, you're going to get some different results.
Right. So the cool part now, and especially having our lab here in the office, is that Marc and I will shape a tooth with one of our patients with you, and it'll be something that wasn't conventional because of the cavity, right? The standard way it used to be shaped, but we can take an impression, make your temporary, go back to our lab and design these inlays and onlays in the most conservative fashion to support it too.
Well, even I find the preparation will change depending on the patient's habits also.
Yeah.
Patient that's grinding and clenching more, I'm more prone to cover the whole biting surface,
right? Cracking,
not to leave a little enamel on the biting surface, which will eventually wear.
Yeah. So to wrap up the thought around a filling versus a indirect restoration, a ceramic restoration, it comes to longevity, comes to cost sometimes. But overall, if you're looking at doing a filling, there'll be more cost over time for that tooth versus the upfront cost of an indirect restoration. So for us, it's healthier and cheaper most times to do an indirect restoration for a medium or large cavity or hole in the tooth, right? When things are small, we do plenty of filling. We do fillings frequently in our practice when things are small because it's the most conservative, simplest solution. So I don't want to give the wrong impression that we're doing only inlays and onlays, and that's always our preference because we do plenty of fillings. We just want patients to think about the pros and cons of these solutions, and it's okay if you have a tooth that's compromised and you say, listen, I want to just do a filling for now. I understand the pros and cons and what's involved, and then next time around we'll consider something stronger, more long-term. That's an okay thing to do for us. We don't mind that. Again, our goal is to more educate you at the implications of the decisions that we make for treatment, so we can make an informed decision around that. We had a few questions about some social media trends, and there was one particular we had a few patients ask us about homemade whitening remedies. So people on social media, there's some people who are making their homemade whitening, mix it in paste. So they're mixing peroxide with baking soda and they're brushing with it. So you whiten your teeth by exposing them to hydrogen peroxide or a version of peroxide called carbonate peroxide, and that gel can thin in your teeth for a period of time. You're going to need at least 30 to 45 minutes is the least amount of exposure that your teeth can have to make any type of difference, and depends on the concentration of the gel. So there are toothpastes that are over the counter that claim to be whitening, and there are these home remedies or homemade whitening gels, and they're not going to do much. I just want to put that out there, that the way that the dental profession does most things is to get the best result. And so when you're trying to get a quick solution to maybe making your teeth whiter, there really isn't one. Just beware of these things that people see. The other trend that came up a lot that a patient mentioned is filing your teeth with a nail file. So we want to be aware of that. If you have a sharp edge, I guess if you're traveling, you have a sharp edge somewhere, call us and we'd rather walk you through to take a look at it. You can FaceTime and figure out how to deal with something that's sharp before you put a Dremel to your mouth. But wishing you well. These talks are really great for us because it gets us to dive deep into topics that we talk with 1 or 2 or 3 patients about that other patients are interested. It's important that we represent our patients through these times that we have through these videos and such. So please reach out to us and let us know what you need more or less of. Please respond to the email, talk with us right here, shoot a text to the office's number. We can get text. We just really want to give you guys things that you're thinking about, things that you're worried about, things that are on your mind, that instead of going to Google or the internet, that we can help to give you the right information around these things. So thanks for the opportunity to take care of you. your trust. We appreciate it so much, and I hope you're doing well. Till next time, see ya.